Welcome. Let's talk about severe sepsis and septic shock. We'll divide the talk into three general topics. One is the 3-hour bundle, the next is the 6-hour bundle, and then the time after. So let's start off by defining some of the terms. Now, sepsis is when you have SIRS or systemic inflammatory response syndrome plus infection. You don't need to have documented infection, just a suspicion infection itself will translate into sepsis. The next term is severe sepsis. Severe sepsis is when you have evidence of sepsis with end organ damage or tissue hypoperfusion. And this can be related through elevated lactic acid levels. Then septic shock, which is the most serious form of sepsis, is when you have persistent tissue hypoperfusion despite adequate fluid resuscitation. So that means at least 30 cc's per kilogram of crystalloids. So if that persists, if the tissue hypoperfusion persists after 30 cc's per kilogram of fluid, so in general 70 kilo prototypical male, that will translate to at least 2 liters of fluid, the tissue hypoperfusion will indicate the patient now is in septic shock. Now, early recognition is extremely important. So let's make sure that we try to understand why it's important, because as the later you decide or suspect it, the higher the mortality. Because the later you suspect it, the later you work the patient up, the later you start treatment, this all translates into increased mortality in these patients. So recognize it early, whether you use vital signs such as heart rate, whether you lose blood pressure, whether you use temperature. Now, further details, you can look at the Surviving Sepsis Campaign Guidelines. The latest iteration is of 2012. But some of the vital signs, again, you want to take that into account with lab value changes as well, such as white cell counts less than 4,000, above 12,000, or even bendemia of above 10%. Now, as we deal with sicker and sicker patient populations or patients with other comorbidities, the usual signs of fever or elevated white cell counts may be missing. Another thing is tachycardia may be missing from a patient on beta blockers, for example, or if someone's on immunosuppressive therapy, they may not mount the fever or the white cell count you generally expect with sepsis. So have a low threshold to evaluate someone with sepsis, especially if they're coming in and you can't really figure out what's going on with them. The altered mental status may not be dementia. It may be confusion related to sepsis and so on. So have a low threshold to start evaluating someone. Now, we found that if you try to enforce a minimum criteria, you do tend to miss out on at least about 1 in 8 patients. So if you have a minimum criteria of 2 aspects of whether it's a vital sign or a lab value, you will end up losing out or missing out on some of these patients. Again, another thing to mention as well is you don't have to wait, or you should not wait for the MAP to drop below 65. If hypotension itself should be defined as MAPs of less than 70, and if you start seeing the patient trend towards that direction, you start needing fluid hydration aggressively. Again, if patients comes in with multiple high blood pressure medications as well, a relative drop of 40 millimeters of mercury in their blood pressure in itself is hypotension for that patient. Now, it's important to identify the source of infection. You can't just say, hey, this guy has sepsis and walk away. A further workup is definitely warranted. You can start off by doing a chest x-ray, blood cultures, and blood cultures should be done with 2 peripheral sticks. If the patient has an indwelling catheter or a port, for example, or a PICC line, you should get 1 from the PICC line or the port and 1 from the periphery done at the same time or simultaneously. The next labs to draw, or next thing to draw, is urinalysis along with a urine culture. Don't just draw the urine culture, because that may be a colonized bacteria and it may not be the true source of infection. So the urinalysis has to be concurrent with this, and if they are consistent with the findings, then you can go ahead and assume that the patient has a UTI resulting in sepsis. If the patient has sputum sample as well, that'll be important to get. If they are intubated, you can either do a bronchoscopy, you can do something called a mini BAL, which is done by a respiratory therapist. Again, you want to get, similarly to the urinalysis, you want to get a culture or a gram stain and culture, and you also want to get a cell count. So a cell count will give you an idea of how bad or how truly positive the culture is. If you suspect that there's no other source of infection at this point, but you highly suspect based on the mental status changes that this may be sepsis, an LP may be warranted, and further investigation with imaging such as CT, abdomen, pelvis as well has to be considered in a patient. So if you don't find a source of infection, keep looking. But none of this workup should stop you from starting treatment, because that's the only thing. A workup of a patient is not going to save the patient. It's actual treatment of these patients. So in instituting treatment with antibiotics and fluids is going to be paramount in their care. A few things before I jump on my soapbox about antibiotics and fluids is checking labs. You want to get a lactic acid level in these patients. You want to get a quick CBC, a Chem 14, which will include a liver function panel, coagulation panel as well, a PT, INR, for example, if you're going to do procedures and so on. But plus, it'll give you an idea of end organ damage in some of these patients. Alright, so treatment. Let's start with antibiotics. You want to give the antibiotics as soon as possible, within an hour. Now, not all antibiotics are the same. You have to figure out whether the infection the patient has is hospital-acquired versus community-acquired, along with the body site involved. Now, the antibiotics has to be given in a timely manner, so time matters. The dose matters. And the type of antibiotic matters. Again, depending on body site, depending on whether the patient has hospital-acquired versus community-acquired risk factors. You can refer to the Infectious Diseases Society of America, the IDSA website, for the latest guidelines in terms of antibiotic choice. The next thing on dose, make sure the patient is dosed appropriately, because an inadequate dose will be just as bad as a wrong antibiotic. You need to make sure that they're dosed appropriately, especially if you're giving medications like vancomycin and so on. You want them to be dosed based on the weight. Don't just assume that when you order pharmacy to dose it that they're going to do the right thing. At that point, you have to lead the team in making sure that the dose is appropriate. The timeliness as well is extremely important. Antibiotics should be given as soon as possible. If you need to go to the pharmacy to make sure that you deliver the antibiotics yourself, please do that. Those are some of the things that you really need to do. Know where your pharmacy is located. As much as everything is IT connected, a human or even a personal sense of urgency will get things moving faster. Learn your environment. Know which buttons to press for help if patient deteriorates. Too many lives have been lost or hurt due to system failure. So know how to circumvent the system when it fails you. So in terms of understanding your environment and knowing where the pharmacy is located, so you can get these antibiotics delivered immediately. IV fluids as well are paramount in treatment. You want to give them normal saline or lactated ringers. Don't waste your time with half normal saline. Don't waste your time with D5 half normal. Do not worry about the sodium levels when someone's in shock or in tissue hyperperfusion. That can be dealt with later. When you need to give them fluids, go ahead and run normal saline or LR. IV fluid boluses, you can refer to how to deliver an IV fluid boluses in the other video. But do not, and that's my pet peeve, is run normal saline 150 cc's an hour and assume you're resuscitating the patient. This is gentle hydration. You're not actively resuscitating someone with that. I don't care whether it's going up to 200 cc's an hour. You're still not actively resuscitating someone. So that really basically encompasses the 3-hour window or 3-hour bundle in most patients. So early recognition followed by instituting IV fluids and antibiotics are going to be paramount while you're trying to source for the source of infection. So these few things need to be covered within the 3-hour bundle. Thank you.